Good afternoon, everybody. Thank you very much for staying on the late Saturday afternoon sessions and hanging in there with us as this meeting is drawing to a close. It's such an honor to be able to come before you today and talk about the most important organ system in the body, the heart. And as we all know, the heart is a muscle too. And we have three really impressive speakers for you this afternoon who are going to be talking about cardiovascular care. And to get started, why don't we welcome Carol Wittlieb-Weber to the podium. She is a pediatric cardiologist and an expert in heart failure and transplant medicine at Children's Hospital of Philadelphia. Welcome, Carol.
Thank you, Dr. Cripe. Hello, everybody. Good afternoon. Oh, that worked. Great. All right, it is so nice to see everyone this afternoon. Thank you so much to PPMD for inviting me to be on this panel with my friends. Though my goal is to talk a bit about creating new cardiac care standards, what I wanted to do is take a little bit of a step back here as I am the first speaker in this session. Whether you are new to the DMD journey or you've been on this path for some time, I am sure you have a lot of questions about the heart, right? Like, why do I have to see a cardiologist? Do they all talk this fast? Though I specifically think that's what people may think when they meet me. I think we have to be honest. You come to see us, and often we're throwing out terms to you as if you, EF, what does that mean? MRI. And then we start talking about cardiac medications, and I'm sure it just sounds like kind of a bit of mumbo jumbo. So I'm hoping that I can simplify some things for you today. All right, a cardiologist is a heart doctor. What's important to know is that there's different heart doctors that have different areas of specialty. It's important to find a heart doctor that knows something about DMD. And also it's important to consider as your heart function is declining or your child's heart function is declining, you may need to switch cardiologists to one that focuses and manages patients with heart failure. Cardiomyopathy. Cardiomyopathy is disease of the heart muscle that can make it harder for the heart to pump blood to the rest of the body. The heart is a muscle. Lack of dystrophin leads to muscle breakdown. Cardiomyopathy is part of the process with DMD. It's important for us to accept that and try to prevent it. Importantly, heart failure and cardiomyopathy are not necessarily the same thing. It's scary because they can be used interchangeably, and heart failure is definitely part of the process as well over time, but it's not necessarily the same thing. Just because your heart muscle might be different, it doesn't mean your heart is actively failing. What I also want to point out is the symptoms of heart failure can be different for patients with neuromuscular disorders compared to patients who don't have a neuromuscular disorder. As your child is aging, if things are changing with other organ systems, like the lungs or the stomach, they're losing their appetite, it's important to ask, could this be the heart? I'm also going to explain some other commonly used terms for you. Ejection fraction, or EF. EF, or ejection fraction, is a measurement of the systolic function of the heart, or the squeeze of the heart. It's actually a very simple measurement. It's the change in the volume of the heart, what percentage of blood the heart squeezes out with each beat. It can be measured both by echocardiogram, which is an ultrasound of the heart, or cardiac MRI, which is a different imaging modality which uses magnet technology and an MRI scanner, but EF can be calculated both ways. Again, it's a percentage. A normal ejection fraction is above 55%, mildly reduced 40 to 55, moderately reduced 30 to 40, and severely reduced less than 30. When your cardiologist is talking about EF and percentage, this is what they're talking about. As we move in to talk about cardiac guidelines, I want you to know that PPMD is sponsoring a revision of care guidelines across the spectrum. When we talk about the heart specifically and what we're going to change or what we're going to say, it's important to remind us, what do the most recent cardiac care guidelines say? These were published in 2018. They're called the Care Considerations. I'm sure many of you have heard of these. This table comes right from that publication, and what it highlights is a couple of things. The most current recommendation from a cardiology standpoint is that you meet a cardiologist at the time of diagnosis and you see them yearly or annually thereafter. You may need to see a cardiologist more than once a year if the heart function is changing or if new heart medicines are being added or adjusted. So at a minimum, your child should be seen by a cardiologist on a yearly basis. When your child sees a cardiologist, the recommendation is that we do some form of cardiac imaging. The most recent guidelines suggest that at a young age, less than 6 or 7, we use the echocardiogram or the ultrasound as our imaging modality. As patients age, the recommendation changes to cardiac MRI. The recommendation in this guideline was that you should consider cardiac MRI age greater than 6 or 7 when a patient can lay still for the MRI without sedation. I will tell you in Philadelphia, we are not able to do a non-sedated cardiac MRI in a 6-year-old. And I will tell you, if you look across the country, most centers are not necessarily doing their first cardiac MRI at that age, and this is something we have to talk about. With regards to the use of cardiac medication, this is a hot topic. So when do we start our first cardiac medication? The most recent guidelines suggest that by age 10, we should have our first cardiac medication on board, which is the ACE inhibitor. As we look forward to new guidelines, what do I think will likely change? I want to be clear that this is not me telling you what the new guidelines are going to be. Though I have the pleasure of leading the guideline revision, there are going to be many cardiologists from across the country that are going to partner on this work. But here's what I think may change. More clarity and recommendations for cardiac evaluation for patients diagnosed via newborn screen. Back in 2018, this was not on the newborn screen, and now we know there are 5 states that are going to be rolling this out. We need to be more specific with how do we handle the very young patients with regards to their first cardiac visit and how often they need to come to cardiology. The suggested age to start cardiac medication. I want to explain a little bit about why this is tricky, right? In order to figure this out, we need to know 2 things. We need to know how early are we really seeing cardiac changes, and 2, we have to have a therapy that we know can work in order to suggest that we use it. Another quick sort of term, cardiac MRI, I gave you that definition. Another term you're going to hear cardiologists say is something called LGE, which is late gadolinium enhancement, also known as fibrosis. What we are looking for on the MRI is early changes in the heart muscle, also referred to as fibrosis or scar, that we know precede the changes in function. So back to cardiac MRI. Our cardiac medication. I'm going to show you just a little bit of data to explain how we may adjust the age with which we'll recommend cardiac medication use. This is cardiac MRI data that comes from Nationwide Children's Hospital. They looked at over 300 patients with Duchenne, 83 of which were less than 10 years old. This figure represents age on the bottom and the findings of LGE or scar on the column on the left. What you can see is over time, there's an increasing percentage of patients with scar on their cardiac MRI. 17% less than 10, 34% 10 to 15, and up to 60% by age 15 and above. What I circled here is if you look, right, I told you 17% age 10 have scar on MRI, but look at age 9 just to the left of it and age 8 to the left of that, right? About 15, somewhere in that 15 to 20% range of patients of that age have scar at MRI. So why are we starting medications at 10 if we know this? Should we push that age down? The other paper that I want to show you, and I'm going to keep this very simple, right? We need to know how early we're seeing changes in the heart muscle, and we have to know that a medication is effective if we're going to suggest it to you. This is a study, and what the authors did, they took patients known to have Duchenne, known to have fibrosis, and known to have normal function. They gave some patients ACE inhibitors, and some patients did not have ACE inhibitors. What they showed is that the patients on ACE inhibitors had a delay in the progression of the fibrosis by MRI, supporting the idea that we can start these medications early. I suspect what you will see is us push down the age by which we're recommending cardiac medications to be started prophylactically. The last thing I want to mention that I think we're going to need to clarify is more guidelines specifically on cardiac medication, cardiac MRI, excuse me. What is the age we should be doing our first cardiac MRI? How often should we be doing our cardiac MRIs? And how is that going to guide our medical management? I think what we're seeing and what I experience at my centers is I'm not sure we're standardized with how we're reporting the findings we're seeing on cardiac MRI and how we're using those to make medical management decisions. And I think this is on us to be more clear to you as our patients in how we're using our MRIs and how often do we really need them. I think we have to be honest that it's not necessarily an easy test to get at all centers, and our patients, your children, don't really like getting that study. As I close my part of the session, what I wanted to share with everyone is as we talk about guidelines, we obviously do our best to incorporate the data, the research that's out there, but we also rely on consensus, bringing together cardiologists from across the country that care for patients with DMD. I want to remind you of the Action Network. We have a muscular dystrophy within it, and we have brought together over 30 cardiologists from different centers to talk about Duchenne and how to care for the heart. We just recently actually published a document on how we handle cardiac medications for our DMD patients, both with normal function and also as the heart function is declining. This is a publication you can access that your local cardiologist would have access to as well. So I just want to emphasize we are all about collaboration and sharing experience. We have a registry within the Action Network where we're currently following over 1,000 patients with Duchenne muscular dystrophy. This is how we'll continue to learn about the best way to use cardiac medications and delay the onset and progression of cardiomyopathy and help with future research projects and trials. As I conclude, I want to give you 2 takeaways for you or your child. Should I be on cardiac medication? If your heart function is normal, it is possible that there will be a recommendation for you to be on a heart medication. It is not uncommon for me to have my teenagers who have normal function on 3 cardiac medications. The ACE inhibitor starting by age 10, the mineralocorticoid receptor antagonist, that would be eplerenone or aldactone. I'm usually starting that by age 12, if not sooner if I have a cardiac MRI. And a beta blocker or a heart rate lowering medication may also be suggested if your child has a fast resting heart rate. As the heart function declines, it is very important for you or your child to be on heart medicines. There will likely be at least 3, and you will see the doses be increased over time as they tolerate it. Once the heart function gets to a moderate or severely decreased range, not only may you be on more medications, but again, it's important that your cardiologist is familiar with managing patients with this degree of heart dysfunction so that all options, medical and outside of medication, can be considered. Lastly, things to remember that will be reinforced over this panel. The heart is a muscle. Find a cardiologist and ask questions. Because symptoms can be different for a patient with Duchenne, if things are changing, pause and ask your doctor, could this be the heart? Thank you.
Thank you, Carol. That was outstanding. You know what? Before we introduce the next speaker, I wanted to put a little shout out to Parent Project Muscular Dystrophy. The transformational changes that have occurred in the field of cardiomyopathy, the understanding of the cardiomyopathy associated with Duchenne muscular dystrophy has really come as a result of Parent Project Muscular Dystrophy pushing the cardiologists in this country to do that, and that would not have happened without this organization's work in this area and the efforts of all of you. So I'd like to give you guys a huge shout out on that. And the next speaker I'm honored to bring to the podium is Dominic Fullenkamp from Northwestern University. He's an adult cardiologist. When we haven't had a lot of adult cardiologists in this space, and we're getting more, and we're honored to have Dominic join the field. And I think you'll enjoy hearing his comments today.
How does this work? Just hit the button. Yeah, okay, great. So Dominic Fullenkamp, as you said, I'm an adult cardiologist. Let's start off with a case. I have a 20-year-old that came to see me typical gene change associated with DMD. His ejection fraction on his heart MRI was 46%. He had some late gadolinium enhancement or scarring or fibrosis, all the same thing. His medicines, he was on alendronate, calcitriol, deflazacort, lisinopril, and metoprolol. So how can we optimize his treatment? So I'm going to come back to this at the end, but I want to take you through a tour of what data do we have, how do we balance the risk and the benefits of treatment for this patient. And apologies to many of the people on the stage and the audience for studies that they've done that's been influential in this area that I'm not including, just don't have quite enough time. So what do we know about heart disease in DMD? Well, we know from the natural history studies, as Carol has pointed out, that by adulthood, cardiomyopathy is found in almost all patients with DMD. And so this is important for me and how I think about how to manage patients that I'm seeing. We know that ejection fraction and scar or late gadolinium enhancement predict outcomes. So the top curve is those patients that have relatively preserved ejection fraction without scarring, and the bottom curve is those patients that have both a decreased ejection fraction and scarring. And those that have either fall in the middle. And so this is also, I think, an important study. This has been borne out in a number of other studies like this. What data do we have to guide decisions? So I'm just going to take one study from each class of medications. So first is ACE inhibitors. And ACE inhibitors, the first study, probably the first study that came out in this was by Dubak et al. They looked at perindopril, not the typical ACE inhibitor that we prescribe in the US, and compared it to placebo. And they found that those patients that had been started on perindopril early had better survival rates than those patients that were not. Mineralocorticoid receptor antagonists. Dr. Cripe has done lots of work in this area. And they've shown that when mineralocorticoid receptor antagonists, these are medicines like eplerenone and spironolactone, are started, they decrease the decline in left ventricular function, decrease scar burden as a function for those patients that were treated. How about beta blockers and heart rate reduction strategies? So some reasonably good data that reducing patients' heart rate with medications like beta blockers, sometimes medications like ivabradine, improve outcomes in patients that have been treated with these medicines. What about therapies not studied in DMD? So one of the newest kids on the block in heart failure, actually not so new anymore, is sacubitril valsartan. This goes by the trade name of Entresto. And there was a landmark study in the New England Journal that was published in 2014 that showed sacubitril valsartan relative to enalapril, which is an ACE inhibitor, as the standard of care in heart failure with reduced ejection fraction, dramatically reduced cardiovascular events in this patient population, including improving mortality. So this study virtually overnight changed the way that we thought about and managed heart failure with reduced ejection fraction. The next class of medicines, SGLT2 inhibitors. These are medicines like dapagliflozin and empagliflozin, Jardiance, Farxiga, they have a number of trade names. These have been studied in heart failure with reduced ejection fraction, and these are diabetes medicines that have been repurposed for the treatment of heart failure, and these have shown reduced cardiovascular events in those patients. These medicines, the reduction in cardiovascular events, I'm just going to say, importantly, is mainly driven by heart failure hospitalization. So when we think about heart failure in the adult world, heart failure with reduced ejection fractions, you will hear adult cardiologists use the acronym GDMT, or Guideline Directed Medical Therapy. And there are 4 pillars. These are medications that we would like to have all adult patients with heart failure with reduced ejection fractions on. These are ARNIs, that's the sacubitril valsartan, or Entresto, or as a second-line ACE inhibitor or an angiotensin receptor blocker. A beta blocker, there are 3 beta blockers that we use: metoprolol, succinate, carvedilol, and bisoprolol. Mineralocorticoid antagonists like eplerenone and spironolactone, and SGLT2 inhibitors like empagliflozin and dapagliflozin. So what therapies should we use, and when should we intervene in DMD? So our approach for our DMD patients is first just echo a comment I think that Carol made, but our traditional measures of heart failure are unreliable in DMD. For non-ambulatory patients, things like shortness of breath on exertion, which is like the most common question that an adult cardiologist is going to ask someone is completely irrelevant. So we're looking at biomarkers. We like NT-proBNP for a variety of reasons. In DMD, there's pretty good data that that's better than BNP. We like troponin I. There's 2 measures that we use, troponin T and troponin I. It doesn't normally matter in patients, but in DMD patients it does. And so we like troponin I. We're doing yearly echocardiograms, EKGs, and heart monitors. We like the 14-day heart monitor if you can tolerate it. We're doing heart MRIs for those that can tolerate it. The frequency is a little bit dependent on the patient and the exact situation, how the heart is doing. We like loop recorders in selected patients where we're unsure about, arrhythmia risk. When we're looking at patients, we're looking at whether patients are on steroids and looking at other things that happen with steroids, like is diabetes present? Is prediabetes present? So we're looking at lipids and we're looking at A1C. And then really important in my practice is, as an adult provider, making sure that we have screened everyone that's willing and wants to be screened that could have been overlooked before they see us. All right. And then what's our typical approach in our adult DMD patients? So once again, functional class is a late marker of disease. We don't use this in decisions on our guideline-directed medical therapy or our defibrillator decisions. So I'd say the minimum therapy that I have patients on is going to be an ACE inhibitor, an angiotensin receptor blocker, a beta blocker, and a mineralocorticoid receptor antagonist. If the ejection fraction is less than 50% or the late gadolinium enhancement, we're thinking about whether or not we should add sacubitril valsartan and Entresto, considering SGLT2 inhibitors. And if the ejection fraction is less than 35% and the patient is interested, we would consider more advanced therapies like defibrillators or cardiac resynchronization therapies in the right patient. What about female carriers? So as Dr. Markham nicely pointed out this morning, when you do cross-sectional studies, that means you just gather a bunch of patients that are female carriers and just look at their heart MRI or their echocardiograms. You're going to find the numbers are a little bit variable from study to study, but about 50% of patients will have some evidence of scarring. There'll be a smaller percentage of patients that have a reduced ejection fraction. So my typical approach for my adult female carrier patients is that in asymptomatic patients without any evidence of disease, we're looking at an echocardiogram or preferably a heart MRI every 3 years. And that we're starting early with medical therapy in these patients if we start to see any abnormalities. So what guides our therapeutic decisions? So we can think about this as a sort of more aggressive versus less aggressive approach. Symptoms, obviously, is favoring more aggressive approach, disease progression, trajectory, like imaging and biomarkers that we talked about, fast heart rate, patient preferences. Less aggressive approaches are going to be things like lightheadedness, electrode abnormalities, cost, more mild phenotypes like Becker or female carriers, and then, again, patient preference. So let's go to this case and quickly decide what we should do for this patient. So I think this patient would be a good candidate for increasing their medical therapy to Entresto, just given the data in the heart failure world. This is a relatively low dose of metoprolol. Sometimes this will be the highest dose that someone tolerates with DMD, but we'll want to maximize the dose of this medicine. I prefer to add a eplerenone in patients just because there's a risk of male breast growth with spironolactone, albeit relatively small. Insurance is usually, at least in the state of Illinois, willing to cover a eplerenone. And then we can consider SGLT2 inhibitors, and just the caveat, I would say there's an increased risk for UTIs with that, which can be a problem in patients. This process can take, I think anywhere between 3 months and a year, and a lot of it is how much the patient, how fast the patient wants to push this. So I often will be sending my chart messages back and forth with my patients to try to get this therapy up to the highest doses as quickly as we can. Okay, so one last thing. So this is a quote from Chinese medicine, ancient textbook, and it went, inferior doctors treat full-blown disease. Mediocre doctors treat the disease before it is evident. Superior doctors prevent disease. And I think we can really think about how to treat patients with DMD and their cardiomyopathy if we look through this lens. When patients have not been treated with appropriate drugs, we really have lost significant ground. When the ejection fraction and we see scarring and biomarker elevation, this is evidence of disease. Really what I think we're all aiming for is starting medications before we can see any evidence of disease. So we have to balance these things with sort of clinical equipoise, where the risk and the benefits are, and first doing no harm, which is an important axiom in medicine. And, I really think that there are opportunities for intervention at all stages of this disease. And so even if you feel like your doctor has placed you in one of in the inferior category, we can achieve a lot by starting medical therapy at any time. So thanks so much.
Thank you, Dominic. That was outstanding. And our last speaker in this session, before we open it up to questions from all of you, is Dr. Chet from Cincinnati Children's Hospital. It's an honor to welcome Chet to the podium. He is the leader, I think, the intellectual leader of the Action Network. He was doing all the hard work and really making transformational change in the field. Welcome, Chet.
So thanks. And Linda was mentioning how we got here, and what I like to tell people is there's no way I would have been involved in any of this without her work at Cincinnati when I was a trainee, seeing what it could become. And I think it's part of what these meetings and the support of PPMD fosters. It brings people into the field who may have been on the outside looking in or have a different interest, and when they can see what a passionate group of parents and patients can do and how we want to move forward, it's inspirational, and it's bringing more and more people into the field. Oh. Yep, you guys are going to trust me, and I can't even use this. Uh-oh. Inferior doctor. Okay, which one do I hit? All right, I got it. Everything's great. So I'm going to talk about emergencies. Part of the problem, and I think one of the biggest things that comes up for families, is actually defining what an emergency is. We see both ends of the spectrum. We see people end up needing urgent care and not getting the right care. Sometimes they get overtreated, sometimes they get undertreated. And so a lot of what today is going to be talking about is creating lines of communication if you are forced to seek care outside of your usual, very experienced DMD team. And why this matters is when you see people who are not used to taking care of DMD or dystrophinopathy, they're going to try and put you in the usual box in terms of what your labs look like, what symptoms might look like when somebody's having a heart issue or another issue, and that's often not appropriate. This is especially important as people are seeking care, not to pick on Dominic, but in adult care. A lot of adult Cardiologists and other specialists don't have experience in DMD. And the reason that is because historically, there was never a transition. We now have more and more men that we're taking care of, and we're finding more and more disease in carriers, and no one ever received training on how to deal with that. So as a result, they're going to try and put you into the same old box. Sometimes that's appropriate, sometimes it's not. And so we really need to define what is an emergency and what is not, and the way that you're going to do that is by reaching out to your teams and making sure that back and forth communication exists. Sometimes, even when you talk to your team, even when other clinicians talk to your team, they're still going to go in a different route. But at least you will have done everything that you can and feel as prepared as possible for when those inevitable urgent or emergent situations do come up. The other thing that's important through all of this is this meeting is so amazing because we're hearing about all of these new therapies, how it's changing the natural history of what's happening. And so when we talk about what we know and what we don't know, sometimes you're going to get answers from clinicians, me included, to say we don't know, and we're starting to see this or that. I'll use the example that happened in the adult session yesterday when we said we're starting to see some patients who have stroke. I saw none of that for the first 10 years of my practice. Now we're taking care of more and more older men who have more and more cardiac disease, and we're starting to see new things. And why that matters in the setting of preparing for emergencies is there are things that we don't know, and so we can't prepare for everything, but you got to have the way that you're going to reach out to your team, communicate, and how you're going to move forward as a family when something unexpected comes up. And the way that you're going to do that and do it most effectively is through multidisciplinary care. Why that matters is sometimes the heart can become a problem even when it didn't start as the primary problem. Somebody has a fall and a fracture. Their heart function has been generally okay, but they have a very traumatic fracture. They come in quite ill, and all of the things that stress brings about on the heart causes the heart function to go down. So even though it didn't start that way, the way that we're going to get through and treat all of the different parts is by engaging all of the parts of your care team. And that means that your care team also has to talk to each other. And I think that is extraordinarily important when you're seeking out a care center. It's not that it's one neurologist, one cardiologist, one pulmonologist. It's a team that should be talking together and engaging with each other. And if you have a team where people don't talk to each other or get along, which does happen sometimes, you have to think about whether that's the best place for care. And usually when we're talking about urgent or emergent issues, we're talking about three specific places. So cardiac, respiratory or pulmonary, and then bone health related, because those are the ones that generally tend to come on relatively acutely. And I like to use the analogy about how we're going to try and deal with this, which is how do I go shopping at the grocery store? So when I was in my 20s and was finally having to do some of this stuff by myself, I would just walk into the grocery store, no list, wander around, go milk, bread, oh shoot, I forgot the peppers, oh my gosh, I forgot the freezer. You keep going around in circles and there's no coherent plan for what's going on. Now my mother refused to go shopping with me as a result of that. She was like, to be able to do this, you have to, you will forget things, even in non-stressful circumstances. You're going to be walking in and out. You're going to have to go back. You need to have a list, and you need to know where things are in the grocery store. And why I say that is because we're going to be talking about circumstances which may be the most stressful situations in your life. And if you don't have a plan for how you're going to deal with it, you're going to forget. It's going to be even more stressful than it otherwise would be. And things may not end up optimal. And so the general things that we like to think about and we give people as part of their discharge after they see us in clinic is how you're going to reach out to us, what your common problems are, and what your baseline testing is. That baseline testing, especially from a cardiac perspective, is important. You heard from Dominic how they do baseline NTB and P troponin. We do the same thing because it can give context when someone comes in with new symptoms. Even for very experienced cardiologists who take care of DMD all day, when someone comes in with new symptoms, it can be a little bit confusing. Knowing what your baseline testing is can help with that communication with the new person who's trying to make sense of it and with your cardiologist at home. The same thing applies for the other subspecialties, but for us, usually the question is about what the EKG looks like, because it often looks abnormal in DMD even when you're doing well, and then what your baseline labs look like, to give a little context and avoid unnecessary testing if people are not used to looking at those labs. The other thing is an individualized care plan. Every single person in this room with dystrophinopathy has a slightly different picture, right? Your echo may be in one place, your rhythm may be at one place, your symptoms may be different, your labs, all of those things. You should be working with your cardiologist to have an individualized care plan to talk about what your common issues are and how to deal with those. We've mentioned a couple in terms of labs and imaging, but the other one that is common, especially in the older men that I take care of, is what is your baseline blood pressure? Because a baseline blood pressure for you, we take care of some people whose upper number is in the 80s, and that is their baseline. They feel good, they do well, their body's happy. And if you wander into an emergency room and they see that, they might lose their mind, activate their whole system, and you end up getting boatloads of fluid, getting put on IV medicines because they didn't know that's your baseline and you feel good. So they're reacting to the wrong thing. And so when we write that out, that can help because at least you can give that to other clinicians to help give them a sense of what the baseline is. And the other part is when you come to our clinic, you see 8 subspecialties. Trying to keep track of what everyone told you is nearly impossible. So being able to have that written care plan is also nice for referral to go back to think about just in general. And then, as I said, really, it's encouraging that communication that's the most important part. When telling your team, hey, I'm going into an emergency room or I'm going to an urgent care, here's what my symptoms are, and then that feedback after the team gives what they think is going on, and that way we can give input as well. I find that 90% of the clinicians want to do the right thing. They are willing to engage with us, and it goes very well. There are 10% of doctors, and that may be overestimating or underestimating, who are just not reasonable. They're not going to talk to us. They're not going to listen. They're going to think they know best, and I wish I had a solution for that. And so the other things that I think are worth noting, and PPMD has supported various ways to go through this, is so knowing who you're going to call for what subspecialty. For us, we try and simplify it as much as possible so that you have central people to call. So instead of having 8 phone numbers to call, you have a couple depending on what you know your issue is. But making sure you have those readily accessible, and for anybody who may be helping take care of your son or daughter, I think is extraordinarily important. This is the only place in here that I'm going to mention it, but I think it is potentially relevant, especially as it relates to blood pressure and cardiac, which is if you're sick enough that you're going into an emergency room, my answer almost always is give stress dose steroids. Because this is where if someone comes in with a low blood pressure, they're starting to try and figure things out. I take the Oprah approach. Everyone gets them. If you're sick enough to be going into an emergency room, my answer, if you ever get me on the phone as part of that triage, is you give that and we'll sort out from there. And then, as I said, there are person-specific considerations that you should be talking about with all the members of your care team. Thanks.
Thank you, Chet. And now we'll open it up to questions. If anybody has a question, step up to the mic and ask away. Okay.
Hi, thank you so much. I'm going to toss out there a little bit of a different 20-year-old and get your take. A 20-year-old whose ejection fraction's at 20%, you're on all the maximum medications, and you have an ICD. What are your recommendations as far as heart monitoring at that point, and what would be next steps?
Great question. We do. I think one is like, what's the trajectory? Is the ejection fraction been 20? This is an important factor. Has the ejection fraction been 20% for 5 years, and their patient's doing relatively well? Versus is this new? We have many adult patients that are like this. I think it depends on how symptoms. Are they developing symptoms of heart failure or not? Getting your heart failure colleagues involved is not a bad idea as well, just to make sure that there's nothing else that they might think in terms of add-on medical therapy. It's a tough one, but all the medicines that we talked about are the ones that are the 4 pillars. And I would say it's a tough one, but CRT is another thing that we sort of think about as well. I don't know. Do you have anything else? You take care of a lot of adults.
The other thing that that comes up, especially in the patients we've taken care of who have ICDs, is do we alter our labs? Do we alter our rhythm monitoring? The answer is we get similar labs. So similar to Dominic, if you're feeling okay, you're getting labs at least every 6 months, potentially more depending on how things are going. We still do annual rhythm monitoring, and the reason is for the defibrillator, most commonly, it is just a single lead, not always, because we're starting to change that somewhat, that goes into the lower chamber. So it detects whether the lower chamber is going fast. We now have more and more evidence, I'd say definitive evidence at this point, that there's fibrofatty change that happens in the atrium as well, and there is increasing risk for atrial arrhythmias, specifically atrial fibrillation and atrial flutter, as people get older. So even if you have a defibrillator, we're still doing rhythm monitoring because we might change your therapy based on the results of that. We may also change how we program your defibrillator without getting too much into the details based on those findings. So we still move forward with all of those other things because we may have ways to optimize. And I think that's one of the things that Dominic said that's 100% right. Even if you're on the right meds, your body is changing. How you may respond to it may change over time, and we may still have to titrate either up or down sometimes. And if we have to come down on those meds sometimes because the blood pressure is going down, that gives us some prognostic information as well.
If I could just add.
Carol, go ahead.
I think when you talk about getting to the most advanced forms of heart failure, I think it gets really complicated. I think, one, it can be really hard as we keep talking about symptoms. How impacted is your son with an EF of 20? Some patients are actually well compensated and some are not. I have sent some patients where it's hard for me to understand for something called a cardiac catheterization to more thoroughly understand the hemodynamics in the heart and the heart output. There are obviously risks and benefits of doing procedures that involve sedation or not. But I think it is worth mentioning that patients with end-stage dystrophinopathy can be considered for advanced cardiac therapies. And by that, I'm talking about something like a ventricular assist device. I think you will hear of cases of patients with DMD that have these heart pumps. I think it's a very complicated evaluation process and discussion that I don't know that we have time to get into. But if you are really wanting to know all of the options, I think it's important to talk to a heart doctor that has a specialty of heart failure and ask, is my son a candidate for something like this? It might not be a yes, but are they a candidate? How does the evaluation process work? And then you could figure out if there's some place that would evaluate your son.
And there's an important distinction. I agree wholeheartedly with Carol on that last point. But if you're going to ask the opinion, go to a place that has put at least one ventricular assist device in somebody with Duchenne. There are very experienced, some of the best centers in the world from adult cardiac care who have never done it. So the answer is almost always going to be no in those circumstances. That may still be correct, but you need to talk to somebody who has done it and to get an opinion there.
Yeah, question here.
My name's Ravi Lippman. I'm 26. I have Duchenne muscular dystrophy. My question is, like, in an emergency situation, things are moving fast, obviously, in that kind of situation. And Dr. Villa said there's not a real great way to answer, like, what happens if, like, you're running into a doctor that's, like, very hard-headed and won't listen to, like, what your recommendations are. I guess, what would you suggest families do to prevent that kind of situation from appearing? Because, I mean, that's obviously a concern with an adult patient with Duchenne, is that we're going to have an emergency situation and we're going to go to an emergency room and the doctors are going to do things that are not proper for someone with Duchenne, and it could exacerbate the problem. So I guess, what would you suggest doing ahead of time, or that families can do, to make sure that their loved one or themselves are well taken care of, even if the doctor doesn't agree with what you're saying?
I think the thing that is probably the most important is know where you're going to go if something happens. Sometimes you don't get a choice. Things are so urgent, they're going to take you to whatever hospital they're going to take you to. But if you're, say, traveling to Las Vegas, you want to be in a situation where you know, if something did happen, I know already where I'm going to go. I view it similar to what we do for people who we've put a ventricular assist device in or who've had a heart transplant. If they're leaving their typical environment, we at least have a plan for, if there is an urgent place, this place is better than that place because you're more likely to get consistent care. And that at least prevents that, oh my gosh, now I'm going to Google it, closest hospital sort of situation, because I think that's the best way to at least try to mitigate that.
It is like the Boy Scouts say, you got to be prepared. And I couldn't agree with Chet more. But this happens all the time. I think you are spot on with this. And everybody on this panel sort of is sitting here because Pat has called us in the middle of the night saying she was called by someone who was in an emergency room with a problem and they needed some additional cardiovascular help from somebody who takes care of young men with Duchenne. And that is not the situation you want to be in. I don't think any of us really enjoy coaching up a physician in an emergency room in rural wherever, right? So I think Chet is spot on. Know where you are going to go when you have a problem and be very proactive about thinking about it. Take your medical records with you and have phone numbers with you. Talk to your cardiologist locally and say, it's possible that I'm going to have a problem. In an emergency, who do I call from your practice?
Okay. Thank you.
Next question. Oh, you're right.
So I kind of had 3 questions. When will the new information that you've been working on be available? And is that something that we will have that we can present of, cardiac care in case we're running into some issues? So first question. Number 2, a lot of the kids obviously may have autism, may have a lot of things that prevent them from getting an MRI. And I want to be understanding better, is a sedated MRI better than not having an MRI? Because we know that they are going to have heart disease. Will it tell you more information? And then if somebody could speak a little bit to the elevated lipids that are a potential side effect of Duvazat and how we should watch that. And I know Dr. Cripe had said some things in another meeting, but I'm curious what your opinion would be about those.
Sure, I'll start with your first question. So as far as updated care consideration guidelines, that project is just getting underway, through PPMD with all of the different aspects of care. So I would expect that to take up to, a year for us all to come together. We do have, from a cardiac standpoint, that publication that I showed you is our Action Network's consensus on cardiac medication. So when we consider prophylactic medications, what we do with dysfunction, that is out there, and that is a reference that you could bring to your provider to say, this is what cardiologists that care for Duchenne are doing. So there is information for you out there. And honestly, we're always willing to talk to people. If your child's cardiologist, wanted to reach out to someone more familiar, we're usually all willing to help. To your second question, the cardiac MRI, I think I'm going to give you my answer. They may have different answers. So I think because we know enough about the evolution of cardiac disease by MRI, and because we're doing prophylactic medications, I have no problem starting an ACE inhibitor or a mineralocorticoid receptor antagonist without an MRI. We know at what age we see the changes because of amazing research that people have done. So if I have a patient with significant behavioral issues, I usually will start the prophylactic medications that I'm comfortable with. I will often try to do a heart monitor if they're able to tolerate it, and consider using a beta blocker if I feel like the heart rate is too high. But there are definitely several medications that I'm comfortable starting and up titrating without a cardiac MRI. We obviously want to check in on the ejection fraction. We can do that by echo. When I would sedate a patient is if really the echo images are so poor, and if I know I'm sedating a patient because I need an assessment of their heart function, I would then do the cardiac MRI in that scenario. So I do think we all will modify our practices based on the patient in front of us, and they may have different answers. And then the third question, the lipids. Personally, I haven't been involved with the lipid question at CHOP in our patients on givinostat. The neuromuscular team who prescribes that are just following the guidelines of when you have to decrease dose or stop. So I will defer to my other colleagues if they have feedback on lipids.
I agree regarding the meds. I would just start the meds, wholeheartedly agree with Carol. And I think we are sorting out how to deal with the lipids. Right now, cardiology isn't taking it on. But I think where it could be, what we're also finding through that screening is a lot of people have abnormal lipids even beforehand. So I think it's going to be one of the next things you're going to hear about in the next couple of years, and where it will become relevant. It may be just like other things where it wasn't relevant before, but if you're going to have abnormal lipids in your 30s and into your 40s, if survival continues to move on the trajectory it is, we're going to have to start engaging the adult cardiologists to deal with the challenges of long-term lipid abnormalities.
So would you be concerned with lipids in somebody who's 12? I mean, when would that be a concern, or would you wait until they're old?
It's all about the numbers and the specifics there, and let's also be very clear, if you have an effective therapy that is modifying your long-term strength, talking about risk and benefits, especially from mild lipid elevation, it has to be put in the context of that.
And then I want to get everybody's questions answered, so is that okay?
Perfect. Thank you.
And then we will move on to you.
Thank you. I wanted to say thanks for such great information and great presentations. This question is really about mostly female carriers. Now that we have started to get some information about when late gadolinium enhancement starts to appear and things like that, do we have some recommendations about when we start to get cardiac MRIs for our female carriers, and when we start to evaluate them, maybe even in the pre-symptomatic phase? As you pointed out, the great doctors will do prevention of disease. So what should we start to do for the female carriers, and when should we kind of start to look? Thank you.
So from an adult perspective, the minute I meet them in clinic, I'm going to get a heart MRI. In Illinois, I haven't had a big problem getting those approved. Sometimes you have to get an echo first just to get through that barrier. But I think your question is probably better answered by our pediatric cardiologist. So.
Well, I think, this is something that we are going to have to dig into with our updated care guidelines. I think when you're talking about the moms, it's a no-brainer they get referred. My understanding guidelines for when you offer screening for a sister would be around 16. I think a carrier sister, once they're diagnosed, should come check in with a cardiologist. I think there's a lot of information to give. Admittedly, I have not seen a lot of sisters. I think sometimes families make the decision to let them decide when they want to get carrier testing. So in my opinion, if a teenager is found to be a carrier, I think they should come to cardiology. Your point is well taken. I think if we look earlier and earlier, we'll probably see changes. And so I would discuss doing a cardiac MRI in a teenager if I saw one. I just want to be clear that I don't have a lot of teenage sisters coming.
Yeah. And if you're symptomatic carrier, you need to be seen from the very get-go.
Thank you.
Yes. So I have a very simple question for my son is 3.5. When shall he start with heart medication? And also, he has had a gene therapy, so that's good to keep in mind. Yeah.
I'll just tell you, in our clinic, we're talking about it beginning at age 6.
Yeah, I think same here. I've definitely changed my practice over time. I would say the average age I'm meeting a patient sort of before gene therapy was probably in that 5-6 range. So I tell families, I talk about the medication. You know, I had been sort of saying, okay, by 8, I will definitely have this on if you want it now. At the end of the day, if I had a family come in and wanted to start a medication at the age of your child, I would do it. I just, you know, I think recommendations have to be based on like the data that we have, and that data that I showed you, the younger we're looking, the more we are finding, which is why I do think that we'll push the age down. I think pushing it as low as 3 or 4, I just think that's going to be challenging because I don't think we have just enough data that, you know, a significant percentage of patients of your child's age have that cardiac involvement. But for me, it's really a discussion with families of here's what the data, here's what we know we're going to do. With gene therapy, what I have done, any patient that I have seen in the setting of gene therapy that's had an elevated troponin at all, I will start a cardiac medication. I will start an ACE. I will offer to start an ACE inhibitor. Not all families want to do that. So there's some information I've gotten from patients that have received gene therapy. So again, there's quite a few things that get factored in, but I would talk to your cardiologist.
Yeah.
Thank you.
Next.
We talk about ejection fraction, but there's not necessarily specificity on left versus right. So I am assuming when you guys are talking about ejection fraction, you're saying left. My kiddo has decreased function on the left ventricle, but the right has not shown any progress towards that. So when do you start looking at one or the other, or how do you start involving both?
Yeah, so I'm so glad you asked that. You know, we do talk, what we are talking about is the left ventricular ejection fraction. We're always looking at the right ventricle. When you do the echo, you're looking at both ventricles. By echocardiogram, as far as functional assessment of the right ventricle, we do have a way to do that. We call that fractional area change, and there's norms for that. So we are always looking at both ventricles by echo and MRI. It's just true, the involvement is on the left side, and we know that by our MRI data. And so, yes, we're talking about the left ventricular function. We see that changing, and the right ventricle remains largely normal for a long period of time. So we're always looking at it, but our management is specific to the changes we are seeing in the left side.
Do you tend to change direction when the right starts getting involved, or is that guidelines that you have set and are working on updating going to remain the same? That's
a good question. You know, if the right side if the left side is declining and we're on all the therapies, or maybe take a step back, I've never seen a patient with Duchenne who just had right-sided dysfunction, if that makes sense. Mm-hmm. So if the right side is going to be involved, that would be, I would say, down the spectrum of the disease where we're sort of already on all of our therapies. So it's not that there's necessarily a newer one you would add if you see the right heart involved.
Okay. I just might add that, like, if you see right-sided dysfunction, you should really make sure the pulmonary status is optimized.
Thank you.
And so talk to the pulmonologist, make sure everything is optimized in that end.
I agree.
Okay, thank you.
Thank you all. And as a follow-up to my friend who, with the ejection fraction of 20 and the ICD implanted, is there anything we can be doing as families, nutrition-wise, in the advanced cardiac world, and do you think we're doing enough in that regard as a community?
Well, nutrition's always wonderful, right? I mean, nutrition Actually, I will answer that question in the sense that, I think the previous session that was occurring with regards to swallowing and nutrition, I think is really important because we've had a number of kids come in, older young men, who have been severely nutritionally compromised and unrecognized almost because it's happened so slowly. And we have put G-tubes in recently and optimized their nutrition and seen significant improvements in their cardiovascular health. Not changing the course, but really helping them feel better. So I think nutrition is important.
I think the other thing that is, so obesity has been shown in a couple of papers from a Duchenne perspective to be associated with worse cardiac outcomes. And so I think optimal nutrition is probably the best way. There have been a number of studies that looked at vitamins or other supplements, and unfortunately all of those have been negative in the overall cardiomyopathy space. There was a lot of hope about especially vitamin D a couple of years ago, and none of it has really borne itself out. So it really just comes to optimizing nutrition, as Linda said, Goldilocks, not too much, not too little.
A very holistic approach, right? I think we're running close on time, and I just want to get this last question in. And you're the last question.
Okay, real quick. My daughter's 33. She has Duchenne. I think we were talking about her EF's 50-ish. She's on deflazacort, lisinopril, metoprolol. And an MRA has never come into any conversation. We never have heard of it. She was wondering, well, why am I not on that? Could it be that she's on a continuous birth control? I don't know.
Could it be that you are not with a heart failure cardiologist? I mean, I just sort of threw that out. And actually, the reason why I do throw that out is because I think the takeaway message here is 20 years ago when I came into the space, no cardiologists understood this disease, right? And now look at this panel as a result of decades of work through Parent Project Muscular Dystrophy pushing the forefront. And now we have the opportunity with 3 really outstanding, talented cardiologists in the pediatric and adult field who are specialized in heart failure management. It is a subspecialty of cardiologists. So your average cardiologist doesn't have the toolkit that these individuals have. So I don't mean it in a very cavalier fashion, but MRIs you guys use, that's your screwdriver and your hammer every day, right? And so what I would do is encourage your daughter just to ask that question and maybe bring that back to their cardiologist.
Perfect.
They probably just haven't read Dr. Cripe's papers.
What'd you say? We'll send you a
They just haven't read your papers.
Okay. Thank you, everybody, for your time. If you have other questions, feel free to come up. We'll answer them. But have a great rest of the afternoon.